that we can be a resource to help address any questions or concerns related to the care for this population. I'm going to do a few epidemiologic slides. I don't want to do many because I want to focus on treatment pathways, but I do think these slides are really important to always bring up to add some context to the situation. So this is a slide from the CDC comparing drug overdose deaths to other kind of epidemics that we have faced as a country, such as automobile.
Oh, Dr. Krans, I'm
Yes.
sorry. Your slides had one away whenever we switched back to the presentation.
Oh, no.
Yeah, if you just want to go to the top and do share my screen, it'll pop back up.
So sorry. How about that? Oh,
It's
there we
okay.
go.
Yep.
Great.
Yep, they're coming up now. Okay, perfect.
Great, thank you. So this is just comparing the severity of drug overdose deaths with other significant public health crises that we have faced in the United States, and just it is now really surpassed in prevalence the impact of these other issues on our society. This is an important slide because I really think it breaks down the nuances. I think when we use the term opiates, it may sound overly simplistic. There's a lot of nuances to how substances are used and substance use patterns. And this really looks at the changing nature of the epidemic by particular type of opioid use and how that has impacted mortality and overdose rates. So initially we saw a rise in prescription opioids being the largest contributor to both the development of use disorders and morbidity and mortality. And then heroin quickly took that over. And now we're seeing predominantly synthetic opioids such as fentanyl, carfentanil, et cetera, contributing to the vast majority of overdose deaths related to substance use. Here's another picture of mortality rates, and I bring this up for this discussion because most of my work, both clinically and from the research perspective, focus on women. This shows you differential by rural, urban status and by the two sexes. So here you see a predominance of increases in the death rate among women compared to men, and in rural areas, much more than urban areas when you look at the impact on women. So a couple things about differences, sex-specific differences in use patterns and morbidity. So arguably, the opioid epidemic has had really a disproportionate effect on women. A couple of reasons for that. So opioid prescribing, which was the primary driver initially of the epidemic, was more common among women. Women are more likely to use opioids chronically and at higher doses than men. And chronic pain disorders are much more common among women, leading to higher rates of opioid use, opioid prescribing. And there's different factors that contribute to pain in these pain disorders that are potentially more prevalent among women than men. Similarly to opioid use, women and pathways to substance use among women are considered to be different compared to men. So women have higher rates of co-occurring psychiatric disorders, higher rates of trauma, abuse, and emotional and psychological distress. They're more likely to report using substances to cope with a mood disorder or a history of trauma and violence compared to men. And women develop physical dependence to substances more quickly than men, or a concept that we refer to as telescoping. Women also have a higher risk of overdose than men, even at lower doses of opioids. So increasing the risk for overdose mortality. So pregnancy is a really important life event. I think we all know that if we have had a child ourselves, or if we know somebody who's gone through this experience, it really is life-changing for all women and can be particularly important for women who have a substance use disorder. A couple of reasons for this. We know that pregnancy changes all women's behavior. I think everyone changes their behavior to some degree during pregnancy, but in regards to substance use, we see a lot of behavioral changes that are different by substance. So in the United States, we see a quick drop off of alcohol. This is a graph of time to abstinence. So the steeper the curve and the more to the left the curve is, the quicker that substance is stopped at the time that a pregnancy is identified. So alcohol use is typically what drops off first. If a woman continues to drink alcohol in pregnancy, she likely has a use disorder. All women should be screened for alcohol in pregnancy. Alcohol is a teratogen. It causes very severe, significant birth defects, leading to a whole spectrum of fetal alcohol disorders, and I think is potentially under-evaluated and under-reported for in pregnancy. But we do see that fall off because of the high prevalence of casual use of alcohol among many reproductive age women. Next, you see a drop-off of stimulants and marijuana, and then the slowest to go is tobacco. Women, if they're going to continue to use a substance in pregnancy, it is most likely to be tobacco. The other important thing, in addition to behavior change related to pregnancy, is healthcare access. So you see a huge engagement in the healthcare system by women who may have been previously uninsured or underinsured, because pregnancy is an automatic eligibility criteria for Medicaid. So just being pregnant allows you to have access to incredibly high quality healthcare. And with access to healthcare, you get access to medications for opioid use disorder, prenatal care, other psychosocial services, and support. So it really is an incredibly important opportunity for many women who may have been disenfranchised from healthcare, not engaged, and when they become pregnant, they initiate healthcare and have access to many things that are incredibly important for their life well beyond the pregnancy episode. So pregnancy really should be seen as an opportunity. I always mention this to obstetric audiences who tend to focus on the pregnancy episode. Addiction or substance use is not a disease of pregnancy. So very few women become dependent on a substance during pregnancy. What happens is women who struggle with addiction happen to get pregnant. We just want to constantly reinforce the chronic nature of substance use, how it is lifelong when dependence has become established. And pregnancy really should be seen as an opportunity to address a very chronic medical process that, again, exists well beyond the pregnancy episode, and that can be managed and treated very successfully. So just wanted to go over the chronic brain disease model that is how we think about addiction, and was first put forward by researchers at the NIH in the early 90s. So this is the way everyone should think about the process. So it's a chronic disease of brain reward, motivation, memory, and related circuitry. So it is a brain disease. And dysfunction in these circuitry due to use leads to biological, psychological, social, and spiritual manifestations. So what happens is the brain chemistry and neurocircuitry is altered after prolonged substance use, and that leads to the individual needing to get reward or relief by recurrent substance use and other associated behaviors. I think all all diseases where the symptoms are characterized behaviors can be more difficult, such as obesity, other disorders where behaviors are really the characteristic way that symptoms are manifested. That versus like high blood pressure, where you're looking at an objective measure. Here you're looking at behaviors, and that can be sometimes difficult for people to think about. So it is not a behavioral issue. Those are just symptoms of the underlying disorder. Symptoms we commonly see is an inability to abstain from using the substance, craving of the substance, an impairment of the behavioral control process to stop doing those things, diminished recognition of significant problems with one's behavior, and a dysfunctional responses. Like other chronic diseases, like like hypertension, diabetes, we see cycles of relapse and remission, and we actually expect to see cycles of relapse and remission. That's the hallmark of a chronic process. So all chronic disease processes have prevalence rates of relapse and remission that actually are completely in line with substance use. So it is not any different than anything else. Again, the symptoms just are slightly different than other disease processes. And like other chronic diseases that go without treatment, just as if you were not to treat your high blood pressure, you would have a stroke, addiction is progressive and can result in disability or premature death. So the identification of substance use is incredibly important in pregnancy. Again, it's the first time a lot of women have really engaged in the healthcare system in a long time. So we want to screen all women using a conversation. We want to talk to all women. It's the beginning of a patient-provider relationship, and it can be a very intimate relationship. And we want to reinforce a sense of trust with patients by talking to them and getting to understand what's going on in their lives. And it's our responsibility to do that. So there's several instruments that can be used to guide this discussion. There are validated tools in pregnancy, and I've listed them there, but those are really meant to kind of prompt the discussion, to prompt the conversation, to see if substance use is occurring and where women are with that process. Selective screening, or kind of cherry picking which women to screen and talk to about substance use, is completely inappropriate. It is not evidence-based. There are no risk factors. Everyone should be talked to about substance use, and it perpetuates stigma, discrimination, and you're going to miss women who actually have problematic use. So urine drug screening is always an ongoing and controversial topic. We should not be universally screening women with urine toxicology screens. I think it's important for people to understand that it's actually a very poor test. It's a very short detection window. It's only capturing use that occurs within a few days of the actual test itself. So, prolonged or intermittent binge use, or depending on the type of substance you're using, may not even be caught by it. It has nothing to do with alcohol. And like I said, depending on the assay you're using or the lab that is processing the result, you're going to miss a lot of substances that are being used that aren't caught by this biological test. So this can be helpful as an adjunct in certain situations where you need to know more information about somebody that you already know is using substances, but it should not be used as a screening tool. I want to talk a little bit about the treatment process. If a substance use disorder, which is somebody who has developed a process where an actual use disorder has set in, it needs to be engaged in treatment. And treatment is not just medication, although medication is a key component to treatment. Treatment is a variety of interventions to try to treat the whole person and the entire situation. I am going to start with medication because they are key to the treatment process. And the two medications we use in pregnancy are methadone and buprenorphine. So just to give everybody a little bit of historical context about this treatment process, because I think it's always nice to go back and figure out where we started and where we are now. There were studies from the 1970s that were really just case reports of a few dozen women that saw women who were dependent on substances come in and were pregnant, and they were seeing stillbirths, and they appeared to be much at greater rates than they were in the general population. And what would happen was women would present in these kind of repeated cycles of withdrawal or relapse or resumption of substance use. And it was noted that after delivery, there was, or at the time of delivery, there was meconium, which can indicate distress. Again, higher rates of stillbirth and concern for a withdrawal process in utero. They also observed a withdrawal process in the infants after delivery that could be severe, leading to sometimes seizures. This is one of the first peer-reviewed articles that came out since 1974 in pediatrics about treatment. And they looked at, again, this incredibly small sample size, several women who were engaged in a methadone treatment program, and a few women who were not engaged in treatment. And the women who were in the treatment program had significantly better prenatal care utilization and much more engagement in their pregnancy in general. They did still have smaller babies, and neonatal abstinence syndrome or neonatal opioid withdrawal syndrome did persist even after the treatment. But the majority of these infants were discharged to maternal care, which is incredibly important because our goal really should be to keep moms and babies together. That's our number one fundamental responsibility as healthcare providers. So that was just kind of the first glance into how effective medication-assisted treatment or medications for opioid use disorder are to help patients who are struggling with opioid use disorder really engage in a very stable recovery process and do actually really beautifully. So here in the red line is the overdose rate that goes down when you see increases in the use of buprenorphine, which is the green dotted line increase, and you see the rates of methadone increase. Now, buprenorphine is later to the stage than methadone, which was the gold standard for the treatment process since the 70s. But you see equivalent decreases in overdose rate when buprenorphine is used in addition to methadone, but that's why those curves are a little bit different. So what is methadone? So it's a full mu-opioid agonist. Mu is the receptor where it acts, and it is an opioid, and it was used long ago as a painkiller due to its opioid effects. And in the early 70s, it was approved for the use of opioid use disorder. It has a very long half-life, and it can be variable. And it's because of its long half-life and because it is a pure opioid, there is a risk of overdose, and it can be dangerous when abused. So therefore, it is dispensed from federally licensed treatment facilities that have a lot of oversight and regulatory protections. So not everybody can dispense methadone. So you have to go to a special treatment facility. And like I said, it's the gold standard for treatment in pregnancy, just because that was the only pharmacotherapy approved for use for this disorder for many, many years. And then came buprenorphine, which is a partial agonist. It does not have the same pharmacokinetics that methadone does. So it's a little bit easier to use, and it doesn't have the overdose potential and abuse potential that methadone has. So therefore, it was approved for outpatient prescribing by, frankly, any licensed physician, and now APPs, and now that special licensure is going away as well. So it is, frankly, in my opinion, a lot easier to use and prescribe than oxycodone. So it's really a very highly effective and, frankly, safe drug to use. Because it is a partial agonist, it does have what we call a ceiling effect or a capped effect. So there in the yellow dotted, there is a certain point where you really don't get any additional benefit from it. So women who may require even more opiate effect to really stabilize themselves may need to use methadone, because you can continue to titrate and titrate and titrate to get better effect, where you kind of max out at a certain point when you're using buprenorphine. And there in the screen, I'll mention this briefly, is one of the other FDA-approved treatments is Naloxone, which is a full antagonist. So it's an opioid receptor blocker. So there's no opioid effect whatsoever because it's an antagonist with Naloxone. I'll briefly mention Subutex versus Suboxone in case anyone is familiar with that quote-unquote issue. So from some of the early studies of buprenorphine in pregnancy, that was really the product that was used and reported in the literature when safety studies were conducted. And then, as many of you know, when something that's what drives our clinical practice pattern, is what was used or / reported in the literature. So that's what drove the use of Subutex, which does not have the naloxone component in it for the use of pregnancy, because there was basically a theoretical concern that the introduction of naloxone in utero would cause potentially a withdrawal process to a baby that had been exposed exclusively to full agonist or pure opiates, but that has borne out to appear not to be true at all. So it really has a low level of bioavailability, and there is really no concern over any an actual neonatal withdrawal process. And there's a lot of benefits to buprenorphine naloxone use or Suboxone use. There's a significantly decreased risk of diversion or abuse with the naloxone component. because the whole point of the naloxone is if you were to inject this, it would not be active. And many states actually don't even have Medicaid coverage for the mono agent or the Subutex. So many states have been using Suboxone only because that's what's covered by insurances. So that we have gone to using Suboxone in our clinic versus Subutex if patients have a strong preference for Subutex, just because culturally we have used that for a long time in pregnancy. We do allow some women to continue to use it, but the vast majority of our patients, we now use basically exclusively Suboxone or the combined agent due to decreased risk of diversion and misuse. So back to the whole methadone versus buprenorphine conversation. This is a summary of the data from the MOTHER trial, which was a big trial published in the New England Journal in 2010, which was a head-to-head comparison, double-blind, double placebo-controlled trial that compared the two medications and the impact on neonatal outcomes. And this really prompted a huge spike in the use of buprenorphine during pregnancy, because we do see that, and it's intuitive that a partial agonist would have less impact on neonatal abstinence syndrome, peak scores, the amount of treatment that's used, the amount of pharmacologic treatment that's used for NAS, and therefore decreased length of stay. So it really was a game changer as far as our options for treatment during pregnancy, and buprenorphine has now become, if not at least half of women using it, almost over 50% of women using it during pregnancy. Whenever we think about outcomes during pregnancy, there's two outcomes to consider. It's outcomes for moms and it's outcomes for babies. So one does not preclude the other, and both need to be considered when developing a treatment plan for pregnant and parenting women. So we do see higher rates of discontinuation with buprenorphine or treatment disengagement compared to methadone, and we do see higher rates of illicit drug use. And this is in aggregate over multiple populations, but so methadone, it can be a really important and highly effective treatment option for many women who would not be able to stay engaged in their recovery on buprenorphine and would not be able to stay in treatment. So methadone remains just as important as a treatment option compared to methadone compared to buprenorphine. So how do we make this decision? It really is a tailored patient-provider decision, shared decision-making process. So each patient has different needs and has different backgrounds, has different use patterns, different experiences, and different preferences. So many women have had multiple experiences with different agents, either illicitly or among friends or with themselves in the past. And so the treatment choice should be individualized, and it should really be what's best for the patient. It's not about the drug, it's about the patient. And if somebody is successfully engaged in a particular treatment program prior to pregnancy, they should not be switched, especially if that treatment has been highly successful to them just because they get pregnant. So again, we have to treat mom effectively, or we're never going to be able to treat the baby. So who are candidates for buprenorphine? So it is often a first-line treatment that we offer to patients who are treatment naive. So they've never used a pharmacotherapy. It's at least something it's easy to start, it's easy to try, and if it doesn't work, it's easy to go to methadone. It's a little bit harder if somebody engages in methadone to switch back to buprenorphine just because of the drug, the pharmacokinetics of the drugs. So we do, if somebody's first line and doesn't really necessarily have a personal preference, we do try to use buprenorphine first. Patients also need to be able to use buprenorphine without a concern for diversion. So somebody who we don't have a concern with that particularly. And then again, if somebody's clearly been successfully treated with a buprenorphine product prior to pregnancy, we would clearly continue to keep them on that particular medication. And of course, if there's no access to methadone, women need to be on treatment, period. So methadone treatment facilities are not as common as buprenorphine providers. So sometimes there's an access issue. I'm going to briefly mention naltrexone. We do not use this frequently in pregnancy. There is some emerging data about naltrexone. Again, it's a full antagonist. It is not an opioid. It is a blocker. but it's a powerful blocker. So you can only use this after an extended period of opioid abstinence. And the whole point of a substance use disorder is you cannot abstain from use. So this is a more difficult drug to initiate unless somebody is able to maintain abstinence for a significant period of time. So we often see it used after somebody has gone through a detoxification program or withdrawal program, or if they're incarcerated and have not been on meds. It can be effective for those particular populations. And it's also effective for alcohol use disorder. So if somebody has co-occurring alcohol use and opioid use disorder, it can be highly effective for those particular patients. But we don't use it commonly in pregnancy. The time we do see it is women who have been on naltrexone and then they got pregnant using naltrexone. And this is a phase 1 study looking at some safety data related to just being on naltrexone and continuing on it during pregnancy, not new initiates. And so far, the early evidence is that this is fine. So this is just an emerging area of research that is exciting. I just wanted to review these kind of general treatment retention rates because I mentioned this briefly about kind of this tension between maternal and neonatal or pediatric outcomes. And, we always try to center with mom because mom is necessary to take care of baby. And we do see significant increases in retention rate or treatment engagement rate long-term with methadone compared to buprenorphine, despite some of its advantages from a drug's perspective. Naltrexone of the 3 agents has the lowest retention rate. And then all of the medication treatment options are much more effective than no medication or abstinence approach measures or intensive behavioral therapies. And again, it's not the word I like to use all the time, detoxification, but a withdrawal process. That and abstinence or non-medication approaches to treatment are not effective for most patients. This is a systematic review that we put together looking at the process of withdrawal during pregnancy, which we do not recommend. And the reason we don't recommend is because we see very poor completion rates. And because we see very poor completion rates, we see high rates of relapse and resumption of use. And when you have relapse and resumption of use, you get overdose and overdose death. So the original concerns, which I mentioned earlier, related to stillbirth and fetal loss in large population-based studies. Of course, those are very small cohort studies in the 70s. We don't actually see that when you look at women who were withdrawn off of medication during pregnancy and those who weren't, but you do see significant rates of treatment dropout and a resumption of illicit use. Because once again, the whole point of having a use disorder is the inability to abstain from use. Despite the highly effectiveness nature of medications for opioid use disorder, they're highly underutilized during pregnancy. We could do more to get more women engaged. This is data from Pennsylvania that showed the blue line is women who are not using any medication for opioid use disorder. So we did see a bump in the amount of women using medications between 2009 and 10, but then we've seen this really plateauing or stabilization of the number of women who are not using pharmacotherapy or medications, and that has been hovered around 40%. So we only see about 60% of women using medications during pregnancy, and there's a lot of room to improve on that. And just here, there's buprenorphine and methadone rates in the blue, in the red and the green. Buprenorphine slightly overtaking methadone, as I mentioned, in prevalence of use. So in order to use a medication, you have to have a prescriber to help you get that medication. And so this is a breakdown of who is giving buprenorphine to pregnant women in the state where I am is in Pennsylvania. And it's actually mostly primary care physicians, which I guess should not be surprising. Second to that is psychiatry or behavioral health, which are probably addiction medicine providers. But what I think could be significantly improved is the rates of OBGYNs that are comfortable prescribing buprenorphine, and it's basically around 5%. So one of our initiatives is, again, because it's frankly safer to use than oxycodone, and OBGYNs use that all the time, is to get more and more physicians of all specialties to feel comfortable prescribing in general and to feel comfortable prescribing in pregnancy. So the next component I want to mention kind of next to medications is kind of trauma and behavioral health interventions, because those can be incredibly important components for some patients. So behavioral health needs. So all pregnant women with opioid use disorder should be evaluated for behavioral health needs. So many women have a co-occurring psychiatric disorder, have to the point sometimes where they have committed suicide or have had suicidal thoughts. And most psychiatric medications are completely compatible and safe in pregnancy. We see a lot of instances where pregnant women are taken off of medications because they are pregnant, and that is only harmful. Most medications are completely safe. And if a woman does not have a relationship with a psychiatrist or a behavioral health provider, it is our responsibility to identify that they have an untreated disorder and help them get engaged with care for somebody to meet their behavioral health needs. Because if we have unmet behavioral health needs, then we're going to be unable to treat the patient to the greatest extent that we can, because we have an untreated disorder that is occurring. This is behavioral health utilization. And again, we separated this, and this is in Pennsylvania, by the use of pharmacotherapy. So one of the advantages to methadone treatment facilities is they're often, you have embedded behavioral health care within that treatment facility. Whereas if you were to go to an outpatient facility to get buprenorphine, that is not always the case. So you have much higher rates of behavioral health utilization in women who are engaged in methadone treatment programs, which some may argue contribute to their ability to retain patients more in treatment and to have higher effectiveness rates. So trauma is basically synonymous with caring for women who have substance use disorders. The prevalence of trauma in a woman's life is incredibly important to her recovery and addressing this trauma. This is so simple, but that's my favorite, and I always talk about it. So what we're trying to do is change the conversation from what's wrong with you to what has happened to you. Because some of these women have experienced tremendous amounts of violence and abuse in their lives, and that has to be dealt with before they're going to be able to engage in their recovery process. A little bit about kind of the social context around substance use, because that also has to be dealt with. So many women, over 66%, this isn't a sample in our population, in our clinic, had a current or former partner that was using illicit substances. Aunts, uncles, cousins, brothers, friends, you name it. People often are surrounded by other people who use substances, and we have to address that and talk about that, because if somebody's going to be using right next to you, that's a huge threat to your recovery. So understanding the social context is key to the treatment process. Note here on trauma, which can occur lifelong, and we see a lot of trauma that occurred in childhood. So neglect, verbal abuse, physical use, a lot of kids observing IPV happening between their parents, foster care experiences, feeling neglected, essentially you name it. A lot of these women have experienced tremendous amounts of trauma, which is a real significant part of what's happening in their life. Intimate partner violence, we see this just incredibly frequently. So over 60% of women have ended an unhealthy relationship in their lifetime. Being physically abused, as I mentioned, stalked. We do see a lot of reproductive coercion. We also see substance coercion, where women are forced to use substances. Their treatment process has been sabotaged by a partner. Again, it's a cliche term, but you name it. We see all kinds of incredibly horrific situations where women are basically completely controlled by a partner and are unable to achieve their recovery unless that's dealt with. Do also want to briefly touch on medical comorbidities, because this is another key component to our care process. So IV drug use is the leading cause of new hepatitis C infections. So we see over 80% of women who have opioid use disorder have a history of IV drug use at one period of time. So asking about intranasal, intravenous injection, and shared paraphernalia as part of part of any kind of clinical intake for somebody who has a new substance use diagnosis. Many women are hepatitis C positive, and many women are often diagnosed with hepatitis for the first time in pregnancy because that's when they're engaging in healthcare and being screened and evaluated for co-occurring disorders. HIV, we screen universally for HIV, and I should mention we now are screening universally for hepatitis C, which is an important public health measure that's come a long way. We do see vertical transmission of hepatitis, although it's not as significant in somebody with an active HIV infection, and it occurs between about 5 and 10% of pregnancies. This is a study that we did on the rate of screening for hepatitis C in pregnant women with opioid use disorder. We found that only 77% of women who had opioid use disorder were screened for hepatitis C. We found that over 60% did have a positive antibody. That does not indicate that they necessarily have a chronic infection, but they at least were exposed to the virus. And then the real important component of this is less than 2% who did have chronic hepatitis C received treatment 1 year after delivery. So you shouldn't be screening for something if you're not going to do something about it. So everyone needs to be screened, and when they're screened, a care pathway for getting treatment with a provider who feels comfortable providing hepatitis C treatment is essential to the process. And then I'm going to speak briefly a little bit on social services provision and resource support. So they're my favorite people. I don't know what we would do without social workers. So social workers and social service organizations are absolutely critical to providing care for this population, because just like we can't care properly for somebody who has an undiagnosed behavioral health disorder or some other co-occurring disorder, we can't care for patients appropriately if they don't have anywhere to live, if they don't have any way to find transportation, if they are incarcerated or have legal issues that are pending, job training, job support, childcare, getting engaged in Medicaid and public assistance. It's the host of services that many women need is significant, and you need providers who are experts in how to help women with those services. There are a lot of programs out there. There are a lot of ways to help women. It's just a complex web to understand how to utilize those services, and a busy provider is often not able to take the time out to do that. So social workers are angels in the clinical setting, and they help us understand really what patients need, provide counseling, provide trauma support, and help us with these resources, which we're unable to treat women, again, if they have no place to live. This is just a little, it's hard to read, and it looks long, but it's meant to look long because these are some of the programming that we provide way beyond medication, at kind of a comprehensive women or person-centered program. So again, family planning, feeding support for the baby, WIC, breastfeeding education, trauma-informed care, as I mentioned, parenting skills training, childcare, housing assistance, infectious disease evaluation, making sure obstetric and postpartum care are provided, and behavioral health. So, all of these different components are critical for the entire treatment process, and it takes a village, but you can change somebody's life in a heartbeat when you're able to provide all of these really important services. All right, I'm going to transition briefly here to talk a little bit about postpartum healthcare. Again, I could go on ad nauseum about any of these issues, so I look forward to questions at the end if anyone has them. Breastfeeding. So breastfeeding is a critical intervention that we can use for all women. Breastfeeding and breast milk are strongly recommended for women who have substance use disorders in their kids. We find that women who breastfeed have a reduction in stress, increased confidence. They feel like more effective parent. They're able to, it helps with bonding and parenting confidence. And for a lot of women, it's an additional motivation to avoid illicit drug use while they're breastfeeding. As far as neonatal outcomes, they're significant. We do see decreased now severity. less severe, not as significant, less significant pharmacologic treatment, less medications, and shorter hospital and NICU lengths of stay. So breastfeeding is really core to what we should be talking to all women about, but especially women who have substance use issues. All right, birth control, contraception. So many pregnancies among women with opioid use disorder are unintended, but in studies, we see that very few women are actually using a hormonal or a highly effective contraceptive method. So we see that condoms are often frequently a method that is used, which is not considered to be a highly effective method. And there's, in comparison to other populations that are matched as far as socioeconomic and other demographic parameters, there's a low utilization of LARC methods, such as the IUD implant. So why is this? Clearly, every woman has a right to determine their own contraceptive method and their own reproductive freedom completely. But there is a thought there's an access issue, that there may be a lack of awareness about available service, mistrust of healthcare providers, understandably, because many providers have been very judgmental and very, very hard for this particular population. And just, like I said, a lack of access and lack of transportation to get to receive contraceptive services. This is a study that we did in our research group looking at postpartum contraceptive methods and interpregnancy interval after delivery. So in this retrospective cohort, we found that over 75% of women did not have a pharmacy-filled method, so not a highly effective method after delivery, which is high. And then of the methods that were most frequently used, again, we see kind of user-dependent methods such as oral contraceptives. So method does matter. When we looked at method and continuation of that method and time to next pregnancy, especially in this population, we did not see any difference between the use of so women who didn't use anything after delivery had the same time to next pregnancy rates as women who used a user-dependent method like oral contraceptives. So basically, oral contraceptives were as effective as using nothing if you look at time to next pregnancy. So LARC methods do work. That's that green in the middle line there, and the red and the blue is nothing or user-dependent methods such as oral contraceptives. So LARC methods are different and have a different profile, and they are highly effective and easier to use because you don't have to remember to use them. So here's a couple issues, emerging issues that I wanted to briefly touch upon. So polysubstance use, or the rise of co-occurring substance use. We've also been trying to keep a close eye on this. So we see an increase in the use of other substances while using opiates across the country. This is a national data set. And what we are seeing is an increase in amphetamine use in rural areas, as well as tobacco use. Here's a schematic of the different substances that are used with opioids. And here you see a rise in tobacco use, also a rise in cannabis or marijuana use in women who are already using opiates, rise in amphetamine use, and then a decline in sedative alcohol and cocaine use. So just a little bit of a prevalence kind of overview of how substance use continues to change and has always changed. Patterns change over time, and irrespective of the opioid epidemic. So this is just a little bit of a window. We're seeing a continued change of women who are using substances are often using multiple substances. So making sure that all of those are evaluated during intake processes. COVID-19, it's a lot to say about COVID-19. It's affected us all. It's hard to talk about how much it's affected all of us, but it's really affected women who have substance use disorders. It's really dramatically changed things. And I think many of you are probably familiar with the latest CDC information that we've seen huge jumps in overdose since COVID. And there's a variety of reasons for that. So the frequency of in-person visits and the spacing between visits and dispenses, especially at methadone treatment facilities, have changed. So when we were seeing patients very closely, They were seeing multiple providers. That has now changed. I think it's coming back to the way it was, but especially in the spring and summer, they were giving lots of take-home doses to patients. We see a lot more illicit use of methadone because with more take-home uses, there is a risk of abuse and diversion. And so there's just a lot more methadone now in the street because it used to be tightly controlled, and now patients were getting a lot of methadone to take home. You're seeing telemedicine versus in-person visits, which for this particular population, it certainly can be helpful to have the option to use telemedicine, but over time, I think an in-person, face-to-face engagement with an individual is incredibly valuable. And I think many individuals they need that. So that has been hard. And just COVID. More unemployment, more financial stressors, kids are home from school, it's hard to get work, it's just hard on everybody. And if you don't have any reserve and you don't have any social support and you're on the edge, a hit like this can really adversely impact outcomes. So for this particular population, we've really seen COVID effects. This is a little bit of data from Kentucky, who saw an increase. Just again, what I was mentioning is an increase in the number of EMS runs for overdose, patients refusing transportation to the ED, but they were identified to have an overdose, and naloxone was given in the field. But just not wanting to engage with healthcare, either due to a variety of reasons, lack of insurance, lack of concern for reporting, those types of things. But we've seen it rise in all of these issues. Just more information about increases in overdose and related to the epidemic. All right, I want to spend a few slides on stigma. So stigma is just a driver of so many problems related to our ability to effectively care for this population. So it's pretty much top of the heap as far as chronic medical disorders that are stigmatized. I think the stigma associated with mental health disorders has improved over time, although that still is a significant issue as well. But substance use, we're really struggling to deal with stigma and the impact of that on patients' care. So what is stigma? I think it's important to name what it is. It's a powerful, complex social and cognitive process that leads to discrediting, devaluing, or excluding of a person or group of people based on a real or perceived difference. And when that is, you see stigma from healthcare professionals, that is just basically undermines and negates their therapeutic commitment to patients. That's everything against what we stand for as providers. And it really does prevent women from seeking care and talking about their substance use. When they feel judged, when they feel threatened. I think all of us, when we feel judged and threatened, don't want to have a conversation with that person. So women can feel that, they know that. And it's a huge problem. And so then what happens is we have a lack of disclosure, we have fewer women engaging in treatment, and then you see a spike in adverse outcomes. And we can all do better at treating all women with dignity and respect, and wanting to know more about what's going on in their life. So one way I think that all of us can do that is in the way we talk. So these are just some examples of images that drive me crazy, frankly. I think the media has been a huge, it just has perpetuated stigmatizing conversations through the imagery that's often used in news outlets. So nobody needs to be showing pictures of needles being injected into anybody. I think trying to catch somebody's attention has sacrificed the care of a lot of individuals, and is inappropriate. And all babies cry. I think, showing a crying baby is not necessary when talking about babies who have been exposed to opioids. So the word addict, the word junkie, the one I care about them all, but addicted babies drives me crazy because not only is it offensive and inappropriate, it's not even like babies. Addiction is has behavioral symptoms, shows behaviors, and babies are not exhibiting behaviors. They're exhibiting a physiologic withdrawal process from prolonged exposure, which is expected after exposure to any substance. So that just term is totally inappropriate. I'd like to kind of end with the conversation about the dyad, because I think in healthcare, you always need to be centered by something, and what is your goal as a provider? And our goal as obstetrician gynecologists are to really focus on the dyad and that unit, which in itself is something far beyond individual moms and babies. So this is a quote that I like to discuss. So what is the dyad? It's a structurally and functionally interconnected metabolic unit shared by a mother and a fetus through the placenta. So in other words, there's really no such thing as a baby. When you set out to describe a baby, you find you're describing a baby and someone. Baby cannot exist alone, but is essentially part of a relationship. And that's the relationship we're trying to preserve. And the way to preserve that relationship is to develop a relationship with our patients. So I'm going to stop there. I feel like I've been talking a lot, and I'm happy to answer any questions or engage in any discussion regarding this topic that anybody may have.
Thank you so much, Dr. Krans. We did have a few questions that came in while you were presenting. So the first one was, how should we frame our language to pregnant women or to the public surrounding substance use disorders, specifically as it would relate to, and they put this in quotes, child abuse during pregnancy?
So substance use is not child abuse. I think that's important to understand. Child abuse is a completely separate entity. So I think, and I'm not sure if the question is getting at how to evaluate a safe environment for a baby when you have a patient who may be using illicit substances. And that's a very important and serious question. So what we try to do is understand what is happening in the environment where the child is. I think this is part of the question. Just if somebody is illicit, first of all, if somebody's engaged in treatment, that's what needs to happen to create a safe environment for the baby, which is why treatment is so important. But if you have a situation where somebody's illicitly using, then you need to understand what's happening in the home environment. And in many cases, it may not threaten the home environment. But that's, are there other family members involved who is primarily caring for the child? Is the child around in situations that may be unsafe? Because that may or may not be true. So there's a lot of additional questioning and a context evaluation to determine whether or not the child may be in a safe place. But I think the initial first pass is substance use is not child abuse, 100%. And if there is a concern, there needs to be a further evaluation of the social context that surrounds that child, and whether or not the provider feels like after that's been evaluated, there is a concern for child safety, because clearly we are mandated reporters, and if there's a concern for safety, that needs to be identified and reported to Child Protective Services. But just face value without knowing anything, individuals should not be creating a kind of one-to-one equal sign between the uses of substances and and abuse. That's helpful.
Okay, thank you. So this came in towards the beginning of the presentation, and they were basically just asking, do you specifically use Aspert when you would be going through a process with one of a patient or a client?
Right, so that would be, yeah, no, I think Aspert is incredibly effective. The foundations of Aspert really are in alcohol, and there is some indication that for other substances that it can be effective. I think the concept behind Aspert, which is universal screening, and this again would be outside of the treatment context, this would be just in the general population, making sure that we screen everybody, and to be, for all providers, to be comfortable with an initial evaluation to see if somebody meets criteria for referral to, intervention and referral to treatment. And I think one of the things that's really helpful about Aspert is, I meant to show this, I have a slide on this, is a lot of times there are some examples of how to ask questions. Because a lot of providers just need those kind of like templates or examples to say, can you, I want to talk with you today about the use of substances to make sure that we're able to provide the highest quality care for you and your baby. Can you tell me a little bit about, the use of these particular substances prior to, during, just way to phrase those questions to let patients know that you want to have a confidential, trusting conversation about it. So I think Aspert is great as a rubric in the general population because it really hammers the need to, beyond screening, that's the point of Aspert, beyond screening, to be able to identify somebody who may have problematic use and to understand the different ways that we can refer them to treatment, which should be part of any screening process. That's helpful.
Yeah, definitely. The next one we had was, could you speak more on the connection between screening and testing? If you do universal screening during prenatal care, is there any specific reason then to also test patients who screen positive if you will be referring them out for treatment?
You mean with urine drug screens? I wonder if that's.
Yes, yep.
Yeah, I mean, this is a ongoing conversation related to when and how to use urine drug screens. Urine drug screens can be helpful adjuncts when somebody screens positive to just have an understanding of the particular substances used. So, but typically only after somebody screens positive and that use has occurred. To be frank, UDSs still are a kind of integral component of the way the world works. They should not be used first line, but I think to not use them at all, treatment facilities are used to seeing them. If you were to refer somebody to treatment, clearly the goal is to ask them if they have, to evaluate for a use disorder and to understand that, and that should be enough. But typically if use is happening, most providers do a urine drug screen as part of that evaluation when it has been understood that somebody is using substances. So it is typically a component when you have crossed that threshold and are actively engaged in how much, amounts, types, those types of things. It usually is part of that whole package of evaluation. So that's kind of how we use it here versus just everyone walking through the door getting a urine drug screen. And we certainly use it frequently in a treatment facility. In our treatment program, they are used very commonly, again, as this adjunctive component to the entire care process, because it is a tool that we have to help with substance exposure, if that's helpful.
All right. The next one was, I recently had a client who was on Subutex for her entire pregnancy. The last 6 weeks of pregnancy, the doctor began to taper the client off of Subutex with the goal of being completely off of it by the birth of the baby. After giving birth, the doctor put the client on Suboxone. Do you know what the reason would be for this?
I would say that's outside of standard recommendations, and I think that's inappropriate practice. I strongly disagree with that. I think that's frankly traumatizing to the mom to take her off of treatment. So this is something I think is important to say. So, the baby is going to be exposed. So then you're just either withdrawing the baby during pregnancy where you cannot monitor the baby, which is what happened in that instance, or you can observe the withdrawal process after delivery. It's not like the baby didn't withdraw during that situation. You just couldn't observe it because the baby was in utero. So what that is trying to achieve doesn't make sense to me physiologically, because that withdrawal is just kind of happens 6 weeks earlier than it should. And the problem with the difference for the mom is that she's taken off her treatment. So the baby withdraws regardless, and you can't even see what's happening. And then you're taking your mom off of the treatment to accomplish that, where you don't have to do that if you observe after delivery. The exposure has clearly already occurred. And so you are incurring incredibly amount of harm and risk to the mom, who could have totally resumed illicit use, overdose, etc., while actually not gaining anything. So I would not recommend that. And no professional organization would condone that as appropriate behavior. So I feel strongly about that.
How the next one was came through whenever you were talking about hepatitis C positive patients. Is breastfeeding okay for someone who is positive with hepatitis C?
Yeah, great question. We do recommend breastfeeding for hepatitis C positive. We do, although with caveats, in the sense if you were to have a cracked or bleeding nipple, especially with initiation of use, when you can have some you can have chafing or those types of things, just to be very cognizant of that. So that's just maternal blood exposure. But breast milk, we consider to be low risk, and we encourage women to breastfeed who have hepatitis. Again, just want to make sure too with hepatitis that people are looking at RNA viral loads to determine chronic hepatitis versus just having an antibody. A lot of women clear the virus, and maybe they'll be antibody positive forever, but they have no viral load. So the exposure risk with the bleeding, cracked nipple concept is really only those who have chronic disease, because they actually have hepatitis, whereas somebody who may have cleared it or have been treated for it but still are antibody positive, they don't have it anymore.
Okay. Regarding OB care while on methadone or Suboxone, what extra fetal monitoring is needed? And do your pregnant patients follow with MFM, sorry.
Yeah, that's institution specific, and I think on the comfort level of providers. At our institution, I see no inherent need to have maternal fetal medicine involved. But I mean, whatever everybody feels comfortable. We do not have, at our institution, we have, we deliver 10,000 babies a year, and we do see sometimes in outlying more rural areas, if a provider is not as comfortable or they may refer and get a consultation from a specialist, but it's not considered a specialist disorder. We would like all generalist providers to feel comfortable with that. So if somebody needs to do that, that's totally fine. It's certainly not a prerequisite at all. But as far as fetal monitoring, different institutions do different things. With any kind of opiate exposure, we tend to do an extended fetal anatomy at our institution. We typically do that for women who've been using opiates, but we don't necessarily do any third trimester antenatal testing, specifically because of the opiate use. We use normal obstetrical indications. We don't do a routine growth ultrasound. We don't do any non-stress test or antenatal testing. Some institutions do that. So, because there is can be a higher rate of SGA and those types of things. So some institutions do growth, and if growth is off, then you could do non-stress testing and those types of uteroplacental tests. But there's no clear consensus on that. It can be considered. Again, we typically use, if there's not another usual obstetric indication, we typically don't. I do want to just bring one thing up again about the whole urine drug screening thing. You know, if patients are engaged in a treatment program, we like to leave that up to the treatment program. So there's no reason for an obstetrician or a prenatal person to be doing recurrent or repetitive urine drug screenings during pregnancy when because the treatment program is going to be doing that. So, you know, if somebody's in a treatment program, you know, and it's separate from the obstetrician, letting the prenatal care process happen without that is what we recommend. So just to allow that patient to have the experience like any other obstetric patient, and if she's engaged in treatment, let the treatment program do the monitoring. That would be part of kind of the treatment package, which would include UDSs.
Okay. One of the biggest problems one of our participants said that they face is where to refer patients.
Yeah.
She has many patients that don't want to go into inner city clinics, and at that point they can be referred to see a midwife, but then the midwife would want a substance use specialist to treat the patient.
Okay. So I'm trying to think of that question, is that they struggle to find obstetric providers to care for that patient. I'm wondering if that question is versus, because there's the struggle to find a treatment provider to make sure that the patient is engaged in a treatment program and receiving medication. And then there's potentially a struggle to provide an OB provider that wants to care for that patient outside of the treatment situation. I mean, sometimes they can be combined, but yeah, I again, this is a stigma. I think this is a stigma issue. I think all care providers should have no problem caring for this population. Again, there's outside of the need to make sure they're engaged in treatment and receiving medication, they're not any different from any other patient. So I don't, I'm so sorry that that is a problem, because that's an awful problem. And I would think the other group that I think is important to consider is family practice. They often provide outpatient obstetric services. And I have been very impressed, at least in our area, with the amount of family practice providers who are prescribing buprenorphine and are doing co-occurring treatment as well as prenatal care. So I think that's another avenue that I think nurse midwifery has been a champion for this patient population, as well as, like I would say, just trying to consider family practice, because that may be another avenue to find a care provider, at least in the obstetrical setting, who's willing to care for the population. And then finding a treatment provider is a whole nother issue. I do want to throw out a huge plug for SAMHSA, the Substance Abuse and Mental Health Services Administration, which is the government organization in charge of substance use treatment across the United States. And that's like the best website in the entire world. They have 1,000 resources. They're all very evidence-based. And there's just a lot of information, training, materials, all types of things. They have a whole expert section. So I would encourage everybody, if they want help with, and they also have a treatment provider locator. So you can put in your zip code, and they also have a specification if that treatment provider is a Medicaid accepting treatment provider, which you want to find Medicaid accepting treatment providers and not cash programs. So you can find treatment programs that are high quality and provide the services that you need through the SAMHSA website, at least as a start. But I would go there all the time.
Would you be able to speak on why you feel that NALS rates and reliable data on the NALS rates are so difficult to gain consensus on? They said that the data is often years behind, in disagreement with the ICD-10 codes that are being used or not, and just why would it be so hard to get to an agreement on measuring NALS?
This has been an ongoing problem. And the American Association of Pediatrics, this has been a constant debate. So a lot of people define NOWS as exhibiting physical signs of withdrawal. So you can define it. So needing those, a lot of times it's coded for just the kids that needed treatment. And that's a subset of the kids that may exhibit withdrawal processes. Some interpret it as exhibiting actual withdrawal, which not all kids exhibit, but exhibiting at least signs and symptoms of withdrawal may not reach threshold to require medical treatment. And then there's the definition of just exposure. So kids that were exposed in utero never exhibited actual signs or symptoms of withdrawal, but they were exposed. Like all of they were exposed. So there's exposure, there's whether they exhibited signs and symptoms of withdrawal, and then whether they treated. And so often all of those are coded differently. And depending on how you think about the process, there are different opinions on how it all should be coded. And there's a significant discrepancy by institution on how pediatric providers are coding all of those things. So with the plans of safe care that have come nationally and are trying to be implemented across many states, the language is exposed. We have struggled even at our institution with making sure that, or trying to make more uniformity among the coding process, which leads to more uniformity in the data. But there's just so much heterogeneity and variability in institutions with how this is performed, depending on how the kids are presenting. That has led to a lot of discrepancies. That's certainly a contributor to it.
All right. Would you be able to speak on the effects on a breastfeeding mother who has had a relapse? Would that affect her even more psychologically by not being able to bond with her baby?
I think the question is, with the presumption that we would no longer recommend her to breastfeed because she has resumed illicit use. I think any conversation with patients, I think if that's how I understand the question appropriately, I think, I think that's that's a tough situation. I think it depends on what the relapse was, frankly. If it was because relapse or resumption of use has a variety of different manifestations, right? It could be A lot of times it's just a one-time situation where something occurred and caused illicit use to occur, but it's relatively self-limited. The patient has a lot of support. We think it's not going to recur again, and then I would completely consider having somebody continue. I would totally have somebody continue to use substances. And that's on one side of the spectrum, and the other side of the spectrum, I mean, continue to breastfeed. And the other side of the spectrum is somebody who may have had a huge resumption in illicit use with co-occurring stimulants, cocaine, polysubstance use, illicit opioids, or whatever the substances are, and it is significant and prolonged. And then in that situation, I would probably recommend not to continue breastfeeding. So I think it depends on the situation. I think all illicit use is different, and there's different situations. So I would leave it. I would try to focus on that context and whether within that context there is a feeling that it's safe to continue to breastfeed.
Okay. Is there anything you can add regarding women who are incarcerated and have opioid use disorders?
They need to be in treatment. So I feel like, we've come a little ways, maybe not, at least in our area, more and more jails and prisons are providing pharmacotherapy with either methadone or buprenorphine. I think the most facilities, especially during pregnancy, usually provide women with some kind of treatment. What I would like to see is that they provide women with both treatment options, because what we do see is women may be very stable on buprenorphine, and then they become incarcerated, and the only option in the jail or prison is methadone. And so then we have to have a woman go on a pharmacotherapy that's not necessary just because of the situation they're in. So, most programs, I mean, if they have a woman detox in pregnancy, I find that to be meeting the criteria of cruel and unusual, but that still may be the case many places. But even beyond that, making sure that women can continue the treatment that they're on. I don't think we will see a situation where somebody's on another medication and they switch them to something totally different, but that may be the case as well. But anyway, I think choices in jails or prison is key. And then, of course, maintaining treatment and not having women have to go through a withdrawal process is key. But it's an area of active work for a lot of people to try to make sure that's the case.
All right. What is your specific program in the Pittsburgh area open to all women with substance use disorder concerns versus only women with opioid use disorder concerns?
Good question. Our program's open to all women, so regardless of age or pregnancy status. And we typically focus on opioid use disorder. But we partner with Western Psychiatric Institute and Clinics, which is in the University of Pittsburgh, which is a fully functional addiction treatment program that treats any kind of use disorder and is through psychiatry. So while we focus on opioids specifically, they are our partner to help with other use disorders, such as stimulant use disorders, alcohol use disorders, marijuana use disorder, those types of things. We offer tobacco cessation because tobacco is still the most commonly used substance and can be as harmful as any other substance in utero. But we're predominantly opioids, but we certainly partner with our colleagues to make sure that we can offer anyone who comes through the door a full complement of treatment options.
Okay, I just wanted to check really quick. Are you okay on time? Because I just want to be respectful. There were a couple more questions.
Sure, that's fine. Yep, that's fine.
Okay. What is the best way to get OBGYN providers to identify substance use, to assist with linking a patient to a social worker to begin the process of doing the challenging work of keeping both mom and baby safe?
So I think, you know, trying to find an obstetric practice that is linked to social services is key. So many obstetric practices do not have social services support. I would say probably the majority of obstetric practices do not have social services support. So unless that support can be provided through another mechanism, that through the county or regional authority, or if that patient is not engaged at all in any services, then to me the most, and we have done this where we have recommended patients transfer from their existing OB provider to another OB provider just because that other OB provider has established relationships with social services providers who are just too necessary not to have during the prenatal experience. So at times we have recommended patients leave a practice because they just didn't have the resources that were necessary for treating the patient. So finding a provider that does have those resources is key, because the reverse is more difficult to do, meaning asking OB providers to somehow find social services support if that's not part of their normal routine. You know, that's just not going to happen within the time period of a pregnancy. But like I said, there may be other county or service agencies that can be connected to independently from the OB provider that can be hooked up for the patient. It's just that what a lot of OB providers, if they just don't have the time or resources to kind of know that full complement, it just whatever is necessary to hook the patient up with those services is what's important. That's helpful.
All right. What are your thoughts regarding how to determine a therapeutic dose of Suboxone while a medical provider is outside of the inpatient substance use disorder treatment program?
Can you help me with that question one more time? So outside, help me with that therapeutic.
Yeah. So it's how to determine a therapeutic dosage of Suboxone while the provider is outside of the inpatient substance use disorder treatment program. So I'm assuming someone is in the inpatient disorder treatment program and you're going to be the outside medical provider taking care of them after they would transition.
Right, sure. So I would assume that before discharge, but again, you know, I don't know how often you can assume that somebody would need to be stabilized, which is at least a good starting dose for what they should be on. You know, so the average dose of buprenorphine is 16 milligrams a day. So you know, that's not doesn't work for everybody for sure, but I'm just throwing out a number there that's like a common average. We go by patient symptoms. So we have patients on 2 milligrams of buprenorphine and we have patients on 24 milligrams of buprenorphine. So, you know, we typically do not go down on a dose in pregnancy because often women require more medication in pregnancy just because of different clearance rates, different pharmacokinetics in pregnancy, and many drugs need to be increased in dosage as pregnancy progresses. And we've found a lot of success with continuing to make women feel more comfortable, engaged in their treatment, and the medication is much more effective when it's dosed appropriately. So what we'll see is we often see, like in the third trimester between like 28 and 32 weeks, we'll see women developing kind of like shaky, you know, restless legs, they can't sleep as much. I mean, you need to make sure that they are able to discuss with you appropriate withdrawal signs that are indicative that they're being underdosed. And we typically increase the dose between 2 and 4 milligrams, especially during the third trimester. You know, and some women come in and they are on very little, or they've been using very little, and We have some women who are on, like I said, 4 or 8 milligrams. But a lot of women, 60, 70% of women will need some kind of dose increase in pregnancy. Like I said, around 4 milligrams. Sometimes you'll see 2 bumps, but like that 3rd trimester bump we see often. But we go by patient clinical presentation. So, we ask them how they're feeling, and if the goal is to make women not be in withdrawal and feel comfortable. There is no magic dose. Dose is not tied to withdrawal. Withdrawal is due to a variety of reasons, including some epigenetic factors. So, doses, we don't talk to women about trying to restrict their dose or minimize their dose. I think that's completely inappropriate. You're trying to treat the disease process, and part of that is making sure they don't undergo withdrawal. So if a woman starts to complain that she's not feeling as good and she's feeling more withdrawal symptoms and just not, quote unquote, working as well as it used to, then we bump them up by 4 milligrams without hesitation. Absolutely. Now, we do go back down after delivery. If we do go above 16 milligrams, we take them back down to 16. We do that over time, just because outside of pregnancy, there's no indication that over 16 milligrams at this time is necessary. But we do escalate to 24 for some patients. A minority of patients reach 24, but sometimes we go, that's our max dosing of buprenorphine in pregnancy, if that's helpful. Oh, the only thing I would mention about dosing is we do a lot of split dosing in pregnancy. So we never do Q-day dosing. And a lot of times we do TID or QID dosing. So we'll do, 4 TID or 8 TID, or some women like to do 4 QID. It's just whatever works for them. So sometimes when you do, so the other thing you can do before you increase a dose, if you want to just try to space the dose. So sometimes we, if 16 is not feeling right, we can say, oh, we'll take it 4 QID and see how you do. And if that's enough, we can bump them up. So we do play around with frequency of dosing over the day, in addition to escalating the dose in pregnancy.
All right. Is there a tool to determine treatment compliance through pregnancy? What variables would be the most important to look at if the compliance would impact the maternal and neonatal outcomes?
I'm trying to think about, does that mean compliant? Do you mean illicit use happening?
That's what I'm thinking. The thing is, there's tools to determine treatment compliance. So I guess how well, they would be compliant with the regimen.
Well, we do use, we talk to women, self-report, we want them to communicate. That's the first thing we say when coming into a treatment program, is we want you to talk to us. So like I said earlier in the presentation, we expect relapse, we expect resumption of illicit use. That's part of a chronic process, but we just want to know about it, because we can't help you unless we know that something is going on that has led to a resumption in use. So we try to really emphasize that's what we care about, because it is, and to have women feel comfortable talking to us about illicit use. If they don't feel comfortable about talking to us about illicit use, then we got a problem. Because then we're not talking to each other, and then the therapeutic relationship is much more problematic. And also, to be super frank, that's why treatment programs also do urine drug screens to help monitor with treatment compliance. It's just another way to monitor illicit use.
All right. How do you currently approach patients who are pregnant and on using MAT, but they're also taking prescribed benzodiazepines for anxiety, and then they put in parentheses maybe even some other psych medications as well?
Yeah, so benzodiazepines, we do we would prefer women not to be using benzodiazepines. They do have an abuse potential, especially with women who have an underlying substance use disorders. However, if a psychiatrist who's like if we have a legitimate care provider or a psychiatrist who says that this is the only way that I can treat somebody's anxiety or whatever, then we do allow women to continue the benzodiazepine as well as the buprenorphine with counseling and extensive communication about the risk of potentially sedation and respiratory depression. But I would much rather, if that's what has been recommended by another care provider as the only other therapy for that co-occurring mental health disorder has to be treated, period. And if that's what is necessary for that, then it is what it is. And if the patient's counseled appropriately, then we continue them on both medications. I think the same conversation could happen for Neurontin, if that's what the patient is discussing, which also has abuse potential. If somebody, if a psychiatrist or a care provider that has training to prescribe that medication thinks that that's absolutely necessary for that patient, it can be a shared decision about continuing on that, but there's a lot of abuse potential for the GABA agents, and this includes Neurontin, Lyrica, those types of things. So we are also very careful with those medications as well as that. So it's a case-by-case situation, but there's no exclusion criteria because we always want to end up with a conclusion that we want the patients to stay engaged in treatment.
All right, the next one is, they said, ideally, I know that folks would have access to all MAT options, but is buprenorphine recommended over methadone or vice versa for a woman who is pregnant and interested on getting onto MAT?
Yeah, if somebody's naive, meaning they haven't been on treatment before and they do not have a preference for methadone based on previous experiences, then we do use buprenorphine first. I think it's worth giving it a try. It's an easy medication to give. So that is, we do consider that to be quote unquote first line in somebody who doesn't have an a priori preference or has not been in a treatment program before.
Okay, can you speak more to the interdisciplinary process to ensure safe newborn discharge? And they did give some specifics on this. It would be involving a mother that refused to do a urine toxicology while admitting to fentanyl use during pregnancy.
So if a patient has a self-reported use of a substance but refuses the urine drug screen, the self-reported use in itself is indicative of her use behaviors. And it, and so it should be treated as somebody who's actively using illicit substances. So the baby should be observed for the development of NOWs and withdrawal symptoms, and social services should be involved to evaluate, especially if there's ongoing illicit fentanyl use, what the situation is. So regardless of the UDS, if somebody is self-reporting use, that is actionable information, both from a baby's perspective, from an observation, and a need to understand what's going on with the baby. Now, in many institutions, including ours, pediatrics would perform a urine drug screen on the baby, even if the mom refused testing. And that's just to know what the baby has been exposed to. The mother has a right to refuse on her end, but from a pediatric care perspective, the neonatologists want to know, just to be able to care for the infant appropriately, what the substance is that the baby may have been exposed to.
Okay. What is the latest on MAT for stimulant use?
It's not good. I think there was a recent New England Journal article on Wellbutrin. I think it was Wellbutrin and Naloxone. Everyone's trying to figure that out. If we could only have some kind of pharmacologic intervention for stimulant use. I think in some patients, some agents can be effective, but from a population perspective and larger studies, without subset evaluations, we have struggled to find something that is highly effective for most patients. So the standard of care continues to be intense psychotherapy and behavioral interventions. Contingency management should not be forgotten as a highly effective therapy as well, especially for stimulant use.
Okay. In your opinion, how long should an OB monitor the mother after delivery while she was on an MAT treatment plan during pregnancy?
Well, she should have a treatment provider if she's getting MAT. So she should continue with that treatment provider and continue to remain in treatment indefinitely. The OB provider, if they feel like the treatment program is not high quality or may have lapses, or if there's a problem with timely follow-up in her treatment program, the OB provider could step in and say, okay, I'm going to see you, weekly for, the next 4 to 6 weeks until we feel like you're back engaged in your treatment program. But if somebody is engaged in treatment, we typically have the patient follow up with their OB provider per usual OB parameters for that institution and whatever their recommendations are in the postpartum period, unless we feel like there is a hole in the follow-up from the treatment provider's perspective, meaning like they can't get back to see their treatment provider in the next week or two. And then the OB certainly should fill in that gap of care. So we just need to understand when the follow-up will occur and how closely that will occur to make sure that the stresses of the postpartum period, which are significant, don't impact a patient's recovery process.
All right, this one goes back to towards the beginning with your slides. So they had said, according to your slide, why do you think that there is an increase with primary doctors administering medication, MAT, but oftentimes the substance use is found through an OBGYN, and the OBGYN's ability to administer MAT is low?
I just think that I say we, because I'm an OBGYN, just are not comfortable with, that's not a good reason, but I think most obstetricians are not comfortable managing substance use, period. Whereas a primary care provider, even though there may not be like specifically an addiction medicine provider, are just more comfortable in general managing disorders outside of pregnancy, and one of which is substance use. They're more comfortable, probably on average, handling many psychiatric comorbidities. They're just more comfortable in general handling those types of things. And for whatever reason, most OBGYN providers, there's not a lot of training within OBGYN regarding substance use. I would say not a lot's probably generous. There's like no training for OBs. That's changing, I think. But OBGYNs are super pregnancy centric. So they can be seen as primary care providers in the gynecologic setting for many women, but that's just for certain issues and not for substance use. I think it's just something that we haven't done for a long, long time, or we haven't done, period. And primary care just have just probably received more training and feel more comfortable in general with a wider array of issues. But I think because it's more prevalent now than some of our bread and butter things like preeclampsia and those types of things, we need to be more comfortable doing it, and at least initiating it in pregnancy, even though we may not be a long-term prescriber / provider for a patient. We do get so many women initiating treatment in pregnancy that I think our role is to get women on treatment. And even if we're not going to care for them for a long time after delivery, at least we've engaged them and started the care process that is our responsibility.
Okay, so we have two more. How would you suggest weaning a breastfed baby with mother that was on Subutex? Any tips or recommendations would be awesome.
Yeah, I think that's a little bit of a misnomer. I think I don't think they should wean any differently than anybody else. It really is a myth that the baby would undergo a withdrawal process. That has not borne out to be like a thing in the literature, and we haven't seen that clinically either. So I think the breastfeeding should be just done per how you would normally counsel a woman who wants to stop breastfeeding, like who's ready to stop breastfeeding. So no, I would just feel super comfortable and confident, just like you wouldn't wean anybody differently who was like on like labetalol or something, So there's such little breast milk penetration of the drug, and I clearly understand that there's the thought of a little bit of drug exposure helping with the NAS, but I still, that even may be, there's such low levels that we have not observed any clinically relevant withdrawal, or there is no concern for that. So I would do per usual breastfeeding protocols for any that you would use for any patient. But great question.
Okay, and have you often found that using the ID dosage helps with adherence and reduce side effects, especially in the third trimester?
Yeah, I think I mentioned this earlier. I mean, we sometimes use QID, so 4 times a day dosing. We're huge proponents of that because I think there also is an effect of taking something. So in somebody, substance use is some of it is just a very behavioral process of taking something on a frequent basis. And so I think sometimes that is helpful for patients. So to be able to frequently take something, that behavior in itself can be therapeutic and help with behaviorally, as well as spreading out the dose over the day. Makes a lot of sense from a pharmacokinetic perspective as far as how long the dose lasts and how it just basically evens out the effect for the mom. So like I said, we do BID 3 times a day, 4 times a day, and for a variety of reasons, both like that frequent dosing behavior as well as pharmacokinetically, we feel like that really helps women, especially in the third trimester where we really start to see those effects. So give it a try.
All right. Well, thank you, everybody, for your questions and participating. And thank you again to Dr. Krans for a great webinar and for answering all these questions. There were quite a few comments that had come in asking, again, just about resources and support. Yeah. So I just wanted to reiterate what Dr. Krans said about the SAMHSA treatment locator.
Yeah. What I'll do, how about I do this? We have compiled, we kind of have a resource list of some really great national resources, because I understand the audience is not local. So I'm happy to give that to you guys at IRETA, and I think that would be actually more helpful than, I mean, my slides people can look at my slides all they want, but I'm happy to forward that, which have a lot of really useful links and tools, toolkits, those types of things. Which a lot of times it's about finding the information. The information is there. A lot of times it's about finding it. So I'm happy to forward that to you guys at IRETA to forward to the audiences and whoever.
Yeah, that would be great. And then we will post that in our webinar library with the recording and then also your slides so that everything can kind of be in one place. So yeah, that would be awesome. And I also want to encourage, if anybody else had a question, please feel free to email it to us at info@IRETA, and we'll be happy to send it over to Dr. Krans and either get a response or, also give her your email if she wants to reach out to you directly. And I did just want to remind everyone of our evaluation and CEU process. So you're going to receive several follow-up emails from us. The first one will be with a link to the evaluation, and the second will be step-by-step instructions on how to obtain your CEUs. Again, please note it can take up to 48 hours for your CEUs to become available, and we would like to especially request that you fill out our evaluation. It should take no more than 2 minutes of your time. And again, we just want to thank everyone for taking time out of your day to join us and participate today. And if you have any questions, please email us at info@ireta.org. And thanks again so much, Dr. Krans. We really appreciate it.
Anytime. Happy to.
Okay. Have a great day, everyone.
Yep, you too. Bye-bye.